Good morning, everyone. I'm Julian Bales. Welcome to the decade meeting celebrating our 10th year for the subcortical surgery group. As we look back upon the past 10 years, I want to try to highlight sort of the inception and the progression and tack that we've taken. So the subcortical surgery group is a users group. We're not a society, but we dedicated ourselves in the early 2010s, teens, to really looking at exploring the last organ of the body to be operated on the inside, which is the brain. And we dedicated to optimizing minimally invasive corridor approach through really emphasizing clinical and scientific collaborative research and applications of technology. And we have tried to continuously promote that. And obviously, we've got a complicated 3-pound organ that has many challenges, as you're all well aware of, not only the function, but also the structure and the anatomy and the major pathways that we have to constantly negotiate. So our subcortical surgery group has done, I think, some major accomplishments for our humble little organization. And as you see here, the first positive clinical trial in ICH evacuation using minimally invasive techniques. We published a book on subcortical surgery, as you see there. And hopefully we have made an impact and will continue to do so. We've reduced brain injury, morbidity, and complications from surgery. We've integrated new technologies, and hopefully we've advanced research and benefit for patients and their families. So this really began probably 11 years ago or more with the concept of a 6-pillar approach based on advanced imaging and tractography and integration of functional centers, navigation, access and cannulation, always transsulcal and not transcortical, advance and progression in optics technology, resection. And number 6 is the most intriguing because that's what do you do or what can you do next after you accomplish this. The MIPS study and the 6-pillar approach, MIPS, I think it was 2015, led to further development and then refinement of the concepts of minimally invasive perivascular surgery. We also have had over 40,000 MIPS cases done worldwide, over 200 clinical papers published, over 550 unique authors, and I think a growing decade of evidence in all of these areas, including very important emerging concepts such as economics and length of stay and quality and patient satisfaction. Our published evidence continues to grow. We publish in the nation and internationally most esteemed journals. And I want to acknowledge our initial leadership. And this was our group that came together for the first time over 10 years ago. And I want to acknowledge my friend and colleague and partner, Amin Kassam, who really was the driving force behind MIPS and the technology, particularly as we look to NICO to provide us safe and efficient passage to the subcortical space. And Amin spent many, many years teaching, educating, traveling, proctoring, and very selflessly to advance this. And he was really instrumental in us getting this off the ground. Our current leadership team continues to evolve, but I want to acknowledge these listed here and others who allowed us to continue to push something in a very altruistic manner to try to see what new technologies would emerge for the subcortical space. Here's some of our brochures through the years. You see everything subcortical, you see comparing and contrasting, and we always wanted to present our complications and be frank about the lessons learned and how we could all benefit. It's also been an example of, not having national pressure or national support to accomplish this. We've done it ourselves. We've had over $1.7 million dedicated by industry to our mission. The years we've had excess funds, we have funded research, particularly to generate pilots data for residents and young attendings. We've had 11 hands-on workshops supported by our vendor and technology partners. And at this meeting, we have 19 vendors, and please spend time with them. And here's a list of them. And we couldn't do this without their support. So as we look to the future, of course, this is a big part of this meeting, and all of your input and feedback would be greatly appreciated. We're looking towards what is the next step. Is it tissue differentiation, biological tissue preservation? Is it BCI, brain-computer interface, directed drug delivery? The list goes on and on. Here's our day and a half starting this morning. And I think you'll find the talks are very targeted and with the world's experts, and we're so pleased to have them. We have two keynote speakers. The first is for the Enriched trial, which is the first RCT showing effectiveness of evacuation of ICH. Dr. Michael Segru tomorrow is another keynote speaker for personalized brain mapping. Today, we're going to look at MIPS in new vascular clinical trials, brain tumor applications, oncology, new GBM trials, and precision medicine. This afternoon, advances in imaging, interventional technologies, improving surgical techniques, and lowering complications. And then after we adjourn later this afternoon, we'll have a networking reception outside on the patio. So tomorrow we will explore BCI and concepts of BCI, and we're lucky to have the first clinical trial for breakthrough designation presented tomorrow. We have futures in subcortical surgery, and also we'll conclude around noon. So a very packed agenda for a day and a half. I want to thank Nico for being very, very supportive and helpful, not only from the technology point of view, but from the inspiration for the different talks and the technology. And we acknowledge and thank again all the different companies which are here, and we couldn't do it without you. So the future for us, maybe it's closer than it appears. The modern age began after the work of Dandy and Cushing in the early 1900s that really focused on convexity surgery. Leaders that advanced the second wave of skull-based surgery, endoscopic surgery, improved optics have had a big part in dropping the mortality to certainly less than 10% and probably less. Since the 1970s, we've had substantial improvements in imaging, the use of CT, functional imaging, diffusion imaging, looking at tritography, looking at the neuronal networks and where they exist and where they connect. So what will be the next major development, and what is the future of neurosurgery? I hope when you leave here tomorrow at noon, you feel that you've gotten a better glimpse of that, and you see how numerous physicians and scientists can come together and try to work for the causes of advancing improvements. Subcortical surgery is certainly minimally invasive, image guided. It depends so much on diagnostic imaging, tissue collection and analysis, not letting brain tumors go down the suction and ultimately through the drain, but also being able to see what data we can get both histologically and molecularly from that tissue. We are going, as you know, more and more robotically, precise, safe, efficient. What about implantation, stimulation? What about the possibility of silicon-enabled BCI, regeneration, reprogramming, re-engineering cells? And if you look at our logo that we came up with 10 years ago, you'll see that brain path port in the frontal lobe leads to removal of cells In that case, at that time, it was unwanted cells, whether it was tumor or later hematoma. But you can see that the tail over at the 3 o'clock position indicates that something may be put back in. And you're going to hear some about that at this meeting. And that really piques the interest of, as neurosurgeons, do we just think about resection, but do we also consider what more we can do, whether it's pharmacologically or silicone-based or other technology. So hopefully that will further whet your appetite for what could be.